Hello, everyone. I'd love to welcome you today from Ombra Health. This is Morris Panner, and we're excited to host the Corporate Leadership Circle Partner Webinar, Streamlining Your Outside Image Management Strategy. And today, we have a particularly exciting group with us. We have Dr. Alex Towbin, Associate Chief Radiology Informatics at Cincinnati Children's Hospital Medical Center, and Dr. Kevin McHenry, Director, Innovation and Imaging Informatics at the University of Texas, MD Anderson Cancer Center. So it promises to be an exciting show. One thing I would like to mention, obviously, we all have our attention turned towards the end of May already, which is the SIIM 2018 annual meeting. So we look forward to seeing you there as well, and a lot of the issues we talk about today, we will be able to join you at the Gaylord National Harbor in Maryland and move from there. So, without further ado, let me just give you a little bit of orientation. My name is Morris Panner, and I'm the CEO of Ombra Health. Today, if you have questions, you can submit them via the chat window at the bottom of the webinar control panel, and we will do our best to get to them. And then one very important piece is at the end of the hour, we'd like you to take a post-webinar survey and submit your request for SIIM IIP credits. So for those of you who are participating, it is a credit available event for SIIM IIP credits. So at the completion of the webinar, simply click the close webinar pop-up window to access the survey, and at the same time you can submit your request for the IIP credit. So that ends the housekeeping portion of the call, and we can move into the content. And let me introduce myself very quickly. I am a healthcare IT entrepreneur, have done a lot in terms of building cloud systems to make it easier to interoperate healthcare data. And our company is particularly focused on imaging, but as we will talk in this seminar, no man and no data is an island, so you really have to think broadly about a lot of different data types. Just a few minutes before we open it to our panelists. Today, I think everybody understands that the state of our industry is probably more in flux than it ever has been. You have healthcare reform, or maybe it's just at this point appropriate to call healthcare change, which is clearly responding to cost pressures. We have patient advocacy and consumerization. More and more patients are sensitive to taking control of their data and their care. And at the same time, you have real stress on the system in terms of the inability to interoperate between and among systems, and still a little bit of an archaic structure to move data. I don't know many people who use CDs and faxes other than healthcare. You see this as challenges across your network. I'm sure all of you facing care coordination challenges. We're particularly sensitive to the pediatric population, both because of our client base and because so many of us are parents and watching dose management, avoiding redundancy, and then watching network growth and trying to get the best care and moving that in the most appropriate way. Imaging is really core to all of this. And I think if you had to think about one data type that has generated the demand for managing data, it would be imaging. And you can see that in the statistics, the dramatic rise that is showing no sign of receding. And in fact, as we'll talk about in some of the innovation sections with discussions around AI and enhanced diagnostic capabilities, this is going to increase, not slow. Now, for some of us, probably the biggest thing we think about every day is how can we make our patients healthier? But also, a lot of us spend time thinking about how can we make the patient experience better? And being able to get access to the data you want is core to this. And I think as we talk through today, so many of the ratings of people's experience often is how did it work in terms of being, I don't want to call it convenience, but was I able to get access to the information I needed? Was I able to move through the system easily? And we're going to address that today because that is core to some of the way people think about quality. So we're going to do something today that I think SIIM is uniquely good at, and I think all of us have to keep getting better at, which is how to marry up the IT and the clinical perspective. So IT is no longer something that can be separated. Informatics really, I think, is becoming a core discipline. I would not just say in healthcare, I'd say it anywhere. If you go to JP Morgan 10 years ago or some period of time in the past, informatics was not considered core. Now, I think in the next couple of years, you're going to start seeing informaticists not just sit at the executive management table, but it wouldn't surprise me if they end up becoming the CEOs and the very top executives in these companies because information is so core to what they do. And in the same way here, the clinical challenges are dramatic, as we all know, but marrying them up with informaticists and marrying that with those capabilities is critical. So, project challenges, we're going to talk a lot about that because one of the things we're going to talk about today is how do we move this data around? How do we get it from the outside in and from the in out? How do we get it into patients' hands? How do we get it into clinicians' hands? And we're going to talk about all these challenges. We're going to talk about staffing challenges. We're going to talk about deployment and training challenges. We're going to talk about security and then finally agreements and policies. And every one of these issues is in the literally sometimes the front page of the newspapers of our towns, even nationally, as people are trying to ensure that you can improve access to healthcare data, and at the same time, you have to manage all these other concerns. So quickly, I think we'll talk specifically, and we'll have an opportunity to ask questions of our esteemed panelists today. But I just put this up here as a quick sort of flashback. When we were all at HIMSS, we talked a little bit about Stanford Children presented and talked about some of the results they got about how to get patients in faster, into the system faster, how they were able to share with some of their network partners, and how they were able to share and enable patients to be more successful in their care. And I think for a lot of those are incredibly important and helpful aspirations as we think about our strategic plans going forward. So with that, I wanted to set the scene for today's event and really turn it over to our panel. We are super lucky, as I mentioned today, to have two really great friends, colleagues. These people are great. They're super generous with their time and insight. And so I know today is just the beginning. Many of you probably have talked to them in the past, and I think this is going to be great. But Dr. Towbin is a radiologist, the Neal D Johnson Chair of Radiology Informatics and Associate Chief of Radiology Clinical Operations and Radiology Informatics at Cincinnati Children's Hospital Medical Center. And with that title, what he really captures is his expertise in enterprise imaging, reporting, and then workflow. And I would add to this even leadership and how to create change in all these areas. So he does tremendous research in this area, but he's also day-to-day in the trenches trying to turn organizations and ensure that they continue to stay at the forefront of change. Then moving into Texas, we have Dr. Kevin McHenry, Director, Innovation and Imaging Informatics, I love the title, at the University of Texas MD Anderson Cancer Center. And he is a distinguished practitioner, was the section chief for musculoskeletal radiology at the University at MD Anderson, but also fundamentally as Director of Innovation in Imaging Informatics. He really has been one of those people who has politically worked through and built consensus around change in an organization with a storied reputation and a national presence, and has managed to do it with great grace and aplomb. As a testament to this, after he did such a good job, they put him in charge of the, not in charge of, but is one of the physician builders in the transition to Epic, and really had an opportunity to coordinate across the system a variety of different data types and a variety of different workflows, and quite frankly, a variety of different personalities and other factors that make any kind of deployment successful. So these people are great. They are right at the core of what everybody is facing today. So let's turn it to our first area of focus, which is the current state of outside image management. And today's panel will be a little bit interactive. I'm going to encourage panelists to ask questions of each other, and away we go. But let me kick it off. Alex, we talked about this. How can you just give us a sense of how things work today at your facility? How are you dealing with these issues? Just a little bit of a scene setter from your point of view.
Yeah, thanks. Thanks for the introduction as well, Morris. I'm happy to be here today and excited to share what we've developed at Cincinnati Children's. So for us, we get, and I'm sure it's going to be similar from MD Anderson, we get CDs and DVDs full of medical images from around the world. Patients are coming to see us, and we're a quaternary care center and a center of excellence for a lot of different conditions. And so we get tens of thousands of images each year coming into our system. Most of them have historically come via CD, although that's changing. Also in our area, all the organizations, institutions in our region were on one image sharing platform. That image sharing platform went out of business, and all of us were scrambling to find a new solution. It turns out each of the institutions in the area found different solutions. And so we've had to work, like many of the people on the call, have had to work with lots of other hospitals using lots of other solutions. And so I think what we've developed is now something that's pretty innovative. We have multiple cloud-based solutions all feeding into our chosen solution. And so the way we've done that, we install gateways from each of the image sharing platforms. Those gateways are the software components that receive images. They allow us to route studies, do some mild tag morphing. It's basically, we're the spoke. The originating site from the image acts as the hub, and they're using their chosen solution. So the hubs or those gateways collect the images, and then they automatically route them to our core gateway, which is our hub. That core gateway then does the DICOM tag morphing, and so for some things, we will prepend the accession number, for example, so that we know it's an outside study and that it does not collide with any internal. We also prepend a medical record number. Sometimes, depending on the workflow that we're choosing from that site, we may morph the institution name as well so that it stays consistent. The gateway manager, so one of our employees, then logs into the gateway and they have it constantly open. And so they're then managing just one location, one gateway, the hub gateway that we use. And from that hub gateway, send the imaging studies into PACS. And they're doing that. We have that type of gatekeeper mechanism because we still need some data transformation. There are times when we need to provide a second opinion, or we're requested to provide a second opinion on those imaging studies. And in those cases, they need to do a match to an order. They need to make sure that the patient demographic information matches with the internal demographic information so that it fits into the patient jacket and PACS. Other times they're just nominated there as a reference-only study, and so they're just pushing it forward, but they're checking to make sure that order is there. So we've gone from having multiple vendors to one vendor solution, our internal solution, to send all of those images and try to do so in a streamlined way. And so far, that's been working very well for us.
Wow. Now, one thing I love about that is the granular level of detail, because I think this is what really has become required. The concept is there that we should share data, but how do you do it is, I think, where the devil in the details. That's where you really where you really hit it. And Dr. McHenry, do you want to add or comment to that, or should we move on to the next question?
I would just comment that the description is similar to experienced here. The question is, how many CDs are coming in? Well, they're not coming into diagnostic imaging physically anymore. We've pushed that out to the clinics and to other institutions, and there's definitely migration away from the CD-ROM, but there's still a tremendous FTE investment in this whole process. At MD Anderson, this is a 16 to 18,000 study per month operation, and all those studies have to get into the PACS, be normalized, as Alex talked about. And that process, even though the CDs are out of the system, is still, that process could use a lot more automation than currently exists today with current infrastructure.
Awesome. That's very helpful, and it kind of dovetails well into this next area, which really is talking about what you've sort of alluded to, which is this as regional care continues. I mean, I think you guys probably at MD Anderson have experienced this for some time, but I think it's something that is a wave of the future. People are, for insurance reasons, are pushing people to centers of excellence. People are consumers who are seeking centers of excellence regionally, nationally. Can you talk a little bit about how you manage the referring physicians? How do you ensure that all this works in terms of the patient experience of getting referred in and then having the right follow-up and continuity of care, whether at your place or someone else?
Yeah, it's really, just in general from the outside imaging, one of the things that I would add is it not only mitigates the need for repeat studies, but it provides an invaluable context, especially in the oncology scenario use case, that as a radiologist, knowing what the tumor looked like a month ago, 3 months ago, a year ago, is beyond words invaluable as you begin to make your diagnosis and understand and communicate that understanding of the aggressiveness of the tumor, how it's responded in the past to other chemotherapies to the clinician. Again, it is one of the reasons why MD Anderson does not have any barriers. There's no limit to the amount of outside studies that come into our system, because we have found over time that having that context of the entirety of the patient's presentation, whether it be a newly diagnosed cancer or somebody coming in for third investigational therapy. That being said, we do have regional care centers here at MD Anderson. So we have our main campus in the city of Houston, but the institution is developing smaller Houston area locations where patients can come. The important is the imaging that's available for those patients is the same as the downtown campus. Now, you ask about referring of patients in the patient experience. I think it's still frustrating for patients and having relatives recently going through a process, having the patient be responsible to go back to their provider, please provide the CD, put it into a FedEx envelope. So we actually have hired a third-party company to actually serve as the patient's agent. So when a new patient is referred to MD Anderson, they not only do they get a medical record number, but they get a call or communication from this third-party vendor, and they're asked, where have you had your imaging? And oh, by the way, we'll take care of it from here. And so that's been invaluable in terms of, I think, in decreasing the stress of the patient worrying about getting their information to MD Anderson, but also increasing the number of studies that are coming in to have a complete picture of the patient as they begin their referral journey to the institution. And do we provide images, patients to images via CD-ROM? Yes, but we're seeing a transition more and more to, if the patient says, to example, to a local, Royal Hermit as an example, is one of our local hospitals. We've developed a process for PACS to PACS transfer. So if the patient says, I need to get this image to my doctor who's at a hospital we have one of the relationships with, a CD-ROM is not captured at all. I really do think CD-ROMs need to just totally go away in this process. If you really point, Morris, the computers today don't even have CD-ROMs on them. And we're giving patients these discs. Well, I can't put this into my iPad. What am I supposed to do with it? So I think we really do need to get to the point where these transfers are electronic and then seamless to the other institution.
Yeah, no, you guys are really painting a picture of interoperability, which is very, very encouraging. And Dr. Towbin, I don't know if you want to add on to that or comment. In some ways, this next question, which maybe should go to you, picks up on that because it talks a little bit about how all this drives to can it improve patient care and can it give patients a better sense of control? And I think Dr. McHenry alluded to that a little bit, but if you want to add on to that or address this as well, it'd be awesome.
Yeah, I'll touch on both of them, I think. There's a lot that Kevin brought up that really rings true. The concept that we provide people with CDs is ludicrous, right? Apple got rid of CD drives on their computers 5, 6, 7 years ago now. Most of the computers in our hospital don't even have an optical drive anymore, and yet we're still producing discs. And so even in the radiology department and the film management library, we have to buy add-ons for our computers so we can manage these things that no one can consume. When you think about it, patients want images for one of two reasons. They either want to see the images themselves, or more likely they're acting as the surrogate to move images along to additional providers. If they want to see the images themselves, the CDs that we give them are useless. They don't have optical drives. If they want to move them to hospitals, what we're doing is asking our patients to act as delivery people. And the solution at MD Anderson sounds fantastic. We've been trying to do more and more electronic image transfers, and we use the same gateway concept. They're bidirectional gateways. And so once we have an installed gateway, it becomes a destination to send from the PACS. We set up a distinct AE title, and we send it directly to the institution. And that works great for hospitals that we have a relationship with. And it's fairly easy to set up a relationship with a hospital if it becomes, especially for something in the region. If it's something that's a one-off, that may not be the best solution, and we have other ways where we can either upload an image to their site or they could download it from ours. But to the point about reducing duplicate imaging studies, that's definitely the case. We avoid imaging studies at a children's hospital. That means reducing radiation for our children who are being cared or reducing anesthesia events if we're talking about MRI. In any case, adults or children, it's reducing healthcare cost. There's no point in repeating an imaging study if it's already been done and it's a suitable imaging study. And so we work hard. As part of our informatics team, that's one of the main ways we're actually caring for the patient in a direct way, is getting those imaging studies in. And it takes hours of our time to deal with the CDs, which is more reason why we're trying to move away from them. And so all of the things coming together with cloud-based solutions are helping us to develop the relationships with hospitals, to pass images forward, to help our patients to get better care that they deserve.
Yeah, it sounds encouraging, although it sounds like both have slightly different approaches, but complementary ones, and there's still a little bit of I don't know what the right term is, but there's still some variation. There's still some moving parts as people are getting to the place they want to be. Why don't I do this? Because one of the things I think is kind of fun about this is we have a lot of great people on the phone too, and I'd like to feed back a little bit some information to the group. So we're going to do a poll at this point. You can see that on your control panel. There's a section for answering the poll. I am going to activate it right now. I'm going to activate our first poll, which is: what image management goal is your facility most focused on in 2018? So the choices are meeting consumer demands, improving our outside image management, finding scalable storage solutions, and using AI to improve current workflows. We're getting some great responses. Wow, so this is kind of interesting. I will close the poll. We can certainly circulate all this data out to everybody, but with roughly half our participants having submitted responses, it's interesting. So we're looking at well over half just on the improving outside image management. And the next is really meeting consumer demand. So it's not some ways not that surprising to me, in the sense that I think with consumerization on the rise, if you're not paying attention to how patients are morphing into consumers, it's tricky. And then obviously these other focus of interest as well. So we'll share all this, and that's pretty interesting. Thank you for participating. So I'm going to go ahead and close the poll. That worked, which is great. And transition to our next topic. So now we're going to talk a little bit about how do you think about selecting a solution. It sounds like we have a group that has a bunch of different solutions and different ways of thinking about it. So this will be interesting to hear how that worked out. So I think it may be your turn, Dr. McHenry, to take the first question here. You may not be, you don't have to answer this exactly. I think the idea of this question is, what should you be thinking about, the key clinical and IT requirements that you had to think about? Can you give us a sense of that, and maybe that will resonate with folks?
Well, I think if you look at the solutions that are out there, they're pretty much not going to discriminate themselves based upon security. They all have security. It's fundamental to that. The IT requirements, I think, it's not that the IT requirements are great, that they're great for the institution that's trying to purchase the system. So I think the first part of the process is not to gather IT requirements, but is to gather operational requirements of what are the use cases that we're trying to achieve. An example, MD Anderson's Trauma Center does not deal with motor vehicle accidents or helicopters coming in, but other institutions that may be a use case. So where are the points where images or information from an outside institution needs to get into the workflow? Identify those processes, and then at that point begin to look for solutions. And I'll tell you, one of the interesting things that was done here at MD Anderson, I guess I can talk about this now, is when we were selecting our vendor solution, we actually sent the vendors a CD-ROM. And we said, don't open up the envelope. There's 3 in there. We're not going to tell you which one to upload. But then during the demonstration call, we said, okay, please put disk number 1. It turned out all the disks were the same, but the vendors didn't know that. And please upload image number 1 to show us your process. And I'll tell you, that turned out to be one of the great discriminators between the different products, how efficiently the workflow. So it really get to the crux that one of our key use cases was to have the disk being uploaded in the clinic at that point, and then how we wanted to assure that the solution we picked would be efficient for that process. Other institutions may have other use cases, but I think that the fundamental thing about selecting a vendor is to understand the use cases that are unique or maybe not unique, and what is the primary driver for a solution in an institution? How many different institutions do you want to share with? Is it local community? Is it doctors that aren't on your EMR? Whatever the case may be, understand that, and that will drive the IT requirements that the solution is necessary to take care of for the institution.
Wow. So it sticks with me, because you really talk almost the way someone would pick a ERP system or other. It was very much use case and operations driven. Dr. Towbin, do you want to comment on that? I just think it's such an interesting, or take it in a different direction.
Yeah, I'll take it in a slightly different direction. That's fascinating to hear how MD Anderson did it. We were looking for something slightly different, because we were trying to solve 2 problems with the same solution, if we could. So I mentioned at the outset our previous vendor was leaving the business, and so we had to find a solution. But our previous vendor gave us 2 different products basically at the same time. They gave us an image sharing solution and a teleradiology solution. And so we were faced with having to replace both solutions. And so we were trying to see if we could get both in one, although that was not a requirement. It was a nice to have. And so we were looking for that. We were looking for a solution that could have some workflow customization. We wanted a solution that would work for all departments in the hospital. So we needed, because we wanted us to be able to grow with enterprise imaging. And so as images are coming in through multiple departments, we wanted each department to have their own area for image ingestion, And so the radiology informatics group did not have to act as the gatekeeper, and each individual site could do it. But at the same time, we didn't want dermatology images littering the radiology inbox. So we needed the different protocols. We wanted something that could work for research. And so we could have an image sharing solution for different research trials, and each trial having its own landing page, for example. We wanted an easy user interface, because we knew that there were times when patients were going to be uploading their own images, and we didn't want to have to be on the phone explaining. We wanted a solution that would be intuitive to the end user. At the outset, we thought that the network mattered, right? And it's similar to the cell phone commercials. The Verizon sells their network is the largest in the U.S., and then Sprint says, well, there's only a 1% difference. Why does that matter? That's, you can't even tell the difference. So we were under, in some ways, the same solution. The network matters. It's easier to share. And what we found through our solution, as we've been building it up with all these different gateways, is that the network really doesn't matter. And so that ended up being a surprise for us. It was the relationships that matter that we already had. And those gateways, and getting gateways from each vendor was crucial to us. So when we were looking, we thought network, we realized network doesn't matter, but in the end, it's the easy technology, easy solution, which in some ways is similar to what Kevin was saying.
Wow, fascinating. This is a great interplay about network, the importance of network. Does network matter? Whose network is it? I think is implicit in that conversation. Great stuff. So let me flip it back. We're now going to fast forward a little bit. It's like a cooking show where we baked the cake. So now we pick something. What were some of the key challenges? And let's talk about security, the things that we've talked about, training and deployment. I'll flip it back to you, Dr. McHenry. You sort of alluded to security being table stakes, but maybe want to talk about some of the other issues or ongoing challenges.
Well, I think you just alluded to it. In this process, you because of the reliance upon network connectivity outside the institution is implicit to this. One needs to work with the IT infrastructure team of the institution to determine what possibilities are available. Can you have direct connections between institutions? Several of those exist at MD Anderson. Between institutions, we collaborate. So tunnels to transfer information. To what extent is the institution okay with having images go to the cloud vis-a-vis coming direct into the institution? And there are risks and benefits of all those processes. But I think the imaging transfer flow has to have the same security level as any process in the institution having data flow into the institution. As far as the deployment, I think it alludes back to our selection process. The vendor that was selected had a workflow that was intuitive. For the radiologist in this process, although the image, I guess one of the things that getting back and to what extent is the imaging transfer solution going to be a viewing solution? At MD Anderson, it's in general not the viewing solution, but can be for immediate review. The end game is to get the images onto the main PAC system, so the clinicians and the radiologists will have the same perception, but the same experience with the images. As far as the agreements in place, really didn't have to change the policies and procedures. They were in place. We just had to assure leadership that the solution that was being put in enabled those policies and procedures to continue.
Nice.
So touch on it, because I think our experience maybe goes in a different direction. It is interesting. I agree with everything that Kevin said, that security is table stake, right? I mean, they're all solutions are pretty much similar. They're all going to say they're secure. And so as we were selecting, that's not a requirement, but it turns out as we're implementing, it becomes a challenge. And it's not an internal challenge, it's an external challenge, because as we are going to install these gateways to our common sending sites, the sites that send to us commonly, the product has to go through their security reviews, and it's not necessarily their chosen solution. So they're going through a security review on something that they don't have a contract with. And oh, by the way, some of those institutions also want to have a contract before they do a security review. So they have to come up and formulate a $0 contract that the vendors have to jump through hoops to get signed and do all the red lines for a contract that's going to yield them no business. Those type of things slowed us down considerably. The other challenge then becomes a project management challenge. As we're rolling out a solution, it's getting to all of the other institutions and rolling out on their time our solution, right? I mean, they don't have much interest. It's not a priority to them. It's not on their operational plan for their year to roll out Cincinnati Children's solution. It's a way for them to send images to us, and so it helps them be efficient. But this is an above and beyond thing that we're asking them to do. And we're trying to do it in a time when we're trying to then get rid of our pre-existing solution. So managing that, both with our vendor, our chosen vendor, and then external organization to organization, those were the biggest challenge. And that is a huge stressor on our informatics team, my internal team. Trying to deal with all those relationships, identify the correct people, to get the external providers interested in using our solution, or to find what solution is going to work between our institutions. And what we found that one is a lot of trial and error to get these working, and understanding workflow, having workflow specialists on our team who really focus on which is going to be the best workflow for each institution, and sometimes that's using someone else's solution as long as it can feed into our solution. But it was and continues to be a challenge to roll this out to everyone else.
Interesting.
If I can add something to that, I think sure. it does bring up the point that you don't have to have perfect to have good enough. So, putting in gateways is probably the end game, but having a way to begin and initiate the image transfer process, where a easy or a common way of doing this is just sending the other institution a link that they can upload the information without using a gateway. I think that was one of the things that we found was good, that we had initial immediate value by fairly technically low intensity solutions, which gave other institutions the comfort and the facilities to then move to more integrated, more seamless integrations as moving forward. So I don't think perfect has to be the initial end game. Good enough, or you can just start the process so we begin to understand what the logistics on both sides to make other institutions more facile with the image transfer process and more willing to accept how there's a benefit to their workflow as well.
So two really nice takeaways around project management and workflow optimization, which isn't just, takes a team. And then the best is the enemy of the good. You're not going to get perfect, but maybe you're going to get, advance in a pretty meaningful way. Let me just, keep it going. I've already put up the next question, and maybe Alex, you could talk a little bit about this. This is maybe trending more towards the perfect than the good, but using imaging to enable other solutions, whether it be a patient portal. How, is that something that you either done or is on the roadmap, or how do you think about that?
Yeah, this is really getting more into our roadmap. This is where I want to be. So I mentioned earlier, when we're talking about patients and their images, they want them for two reasons. One, they want to look at it because they're interested, or two, they want to share it with another provider. There's no reason that they can't do all of those things on their own, right? With the technology exists, it's not that difficult to implement. To have viewers enabled in the EMR, to let them see images, let them stream through our solutions, and then to push images on their own or download images on their own if they'd like. All of that stuff is possible. It's on our roadmap, but it's not been implemented yet. But we think it's doable, and it's where we need to move. I think we need some of our vendors to help us a little bit to do that, particularly the EMR vendors. It's a little bit, and with some EMR vendors, it's difficult to image enable the patient portals, but it's not impossible.
Got it. And Dr. McHenry,
we see the cloud as an indispensable technology for moving forward. As Alex mentioned, gateways being set, that has been done, but really do see the cloud decreasing the complexity of these image transfers. As institutions become more and more facile and more comfortable with the cloud, I think it tremendously simplifies without sacrificing security. This whole, the idea of moving, the logistics of moving images safely between one institution to the next, and also having the patients be comfortable with their images not being contained on a disk that they can feel, but going to a secure way of image transfer that's efficient, that allows them to get the care they need downstream. We can talk later about how the cloud potentially even gets more interesting in terms of image analysis and some of the innovations that will happen. But I do think the cloud is going to be the ultimate solution to this problem. Images, it's much easier for institutions to create cloud-based transfers than go through the logistics of hardwired physical connections between institutions.
No, it's a great reflection, and in some ways it takes us to our next poll question, which is, how does your facility work to improve your referral network? Because so much of this is about expanding access and enabling people to access care and for care coordination. So the poll is in progress, and the questions are coming in. People are starting to vote. And, how do you work to improve your referral network? And it seems like the early, fairly distributed, this one, although report turnaround time seems to be significantly ahead, although new technology investment and referring physician portal are also in there. I'll let it play out a little bit, and we'll share all these results. But as you will be able to see, we are looking like turnaround time, just being responsive is the majority response to improving a referral network. So I'll let it run for another second or two and close it out, and we'll of course share all this. But I think one of the lessons of this is just being able to be responsive is one of the cores of improving these networks. So let me turn to our next big topic, which is benefits from having gone through all of this complexity, and where do you end up? So, in some ways we've covered some of these things, but maybe just a little bit more of a explicit benefit statement at this point. In other words, I think people are always asking themselves, is it worth it, and why? So what have been some of the outcomes? Dr. Towbin, you want to take a first crack at it?
Yeah, one of the first and easiest outcomes is that we've decreased the number of CDs. CDs suck, right? And they suck for a lot of reasons. They suck because people do all sorts of silly things with them. We have some institutions nearby that put password protection on it but don't share the password with anyone, so no one can access them. They forget to burn them. We get CDs that have the label printed on the readable side instead of the side the label's supposed to be on. They do everything they can to screw it up, and then they repeat it over and over again. So if we can decrease the number of CDs, that's a good thing. And what we found is as we move to cloud-based solutions, we still have problems, right? We still get bad DICOM. We still get private tags that screw up. We have accession numbers that are too long, things that just don't work, that aren't able to be ingested into our packs. The benefit, though, is that we can build a solution, and I see a problem, then use DICOM tag morphing to fix that problem, and prevent it from ever happening again. And so we can propagate solutions and make sure that from an institution, if they always do the wrong thing, or if they always have an accession number that's too long for our packs, that's a DICOM violation, or they're always generating a private tag that fails in our packs, we can just delete it and do so every time and fix it. And so that's been huge. It's the decrease in the number of problems from CDs has been huge for us.
Got it. And, I'm going to, just given where we are in the hour, maybe shift it over to you, Dr. McHenry, just on some lessons learned. And, there's some benefits, but there's also some lessons.
I think the lessons learned is fundamental. One has to understand the use cases at the institution that's implementing these systems, and what is the value proposition that's necessary to have these systems in place. I think one of the things too that in terms of interoperability, we haven't really talked about that, but one of the challenges we're seeing now is having access to the prior reports of the study. So the image and getting the images into our system, that's a pretty much done deal. But now we're struggling with having access to the imaging reports that are associated with those imaging, because oftentimes they're coming in through a different pathway. To Morris T, or they're on that fax pathway, So the CDs are coming in, and the reports are coming in by fax and going through an entire different pathway. So if there's one thing that the requirements would like to see is a bigger emphasis on getting access not only to the images but the reports that were generated to understand what was the understanding of the patient's disease process at the institution that the images came from.
Nice, very, very helpful. And so, in some ways we haven't talked a ton about interoperability, but it does sound like that's one of the underlying factors. We haven't said the word as much, but I think it sounds like that is the essence of what we're trying to put together, and to have true interoperability, you need all the information.
Right. And the issue too is, with interoperability, is how the images are named at other institutions, the naming conventions. Even we did a study, we presented RSNA a few years ago, that oftentimes you don't, even the institution name is default name here. So so in terms of the provenance of the images, where they came from, I think there needs to be much more attention paid to that part of this whole problem than currently does today.
Perfect. No, I think that one of the factors is that it's not just as simple as saying, here's the imaging. You've really got to be able to match it to the patient, know where it came from, know how to reconcile all the different identifiers, accession numbers, and so forth, that make this a very complicated business. I think we have time for one more quick poll before we go to our last section on innovation. So what are the greatest challenges in developing an outside image management strategy? And I'll be curious, we've heard now some lessons learned, some challenges, but I'm going to open this poll to get a sense from our audience, many of whom I imagine are up to their neck in this, which is why we've had such a great response, I think, to this webinar, to hear from experts who have been grappling, I think is pretty inspirational. That's interesting. This one surprises me. Having the staff to support the endeavor seems to be the clearest challenge. That's interesting. I don't know. Maybe, wow, really by a pretty clear majority here, almost a super majority.
Morris, I'll speak to that. The results are coming in, because the process today is still too manual. Even though the images are in the cloud, when the images come into the institution, there is a manual process to create the order, to identify what the image study is, normalized to the institution's naming convention, and to assure that, to Alex's earlier point, that the DICOM tags are correct, that it's not going to crash the PAC system. So this is a much too manual process today, and that is even an issue here constantly. having enough resources to not get overwhelmed by these studies coming in from the outside.
Yeah, I would echo it. It's a huge problem even today. Even in electronic image sharing solutions, we still have to do everything to normalize DICOM. You know, to our institutional names, to our medical record numbers, to our naming structures. All of those things take time, and it's a huge burden if you're really doing this. It's an expensive burden, and it's a huge burden on a department. And that's one of the things maybe I didn't answer completely, and things that we were looking for when we were looking for other solution for our solution. We needed to have something that would allow us to do cFind and to search and edit information at the patient level for lots of studies. We get DVDs full, or a whole imaging jacket from a patient, and it could have hundreds of studies. And in most solutions, we have to do that type of data correction study by study. We needed a solution that would allow us to do it for the patient at the patient level and edit all of their data, all of that data for all of those studies at once.
Super helpful, super helpful. Now, in the very last section here, I like to entitle this section, has two names. It says Paving the Way for Innovation, but SIIM is such a great organization and we only have a couple of minutes left. So really this section should be entitled Come to the SIIM annual meeting to learn about all this, because this is a multi-day topic, not a multi-minute conversation. But I think the crux of this is, as you start thinking about interoperability, as you start thinking about agile access to imaging, what do you think it opens up? And we have a couple of slides here that I'll show them so that you get a sense of the span, some of the big trends, some of the other kind of technology that you can enable, and then some of the things that you can do in terms of automation and other types of systems that change it. I'm going to throw all of them into the mix and let people kind of pick and choose what they want to key on. I think we only have a couple of minutes left in the hour. So maybe if each of you could take a minute or two to give us your sort of favorites in this area. What's coming and what are we enabling? So Dr. McHenry, you want to give it a start, and then we'll turn to Dr. Towbin.
I'll keep it to a minute. I think that artificial intelligence is going to impact lots of things in radiology, including the imaging management of outside studies. I do believe that as the images get to the cloud will become much more intelligent, do the normalization for us in the cloud. So when the images get to our systems, they have orders already generated automatically. The images are normalized. I do also, to be provocative, think it's naive to think that the patient will not begin to explore other ways to analyze their images. Yes, they may want to send their images to MD Anderson, but do they also want to have them analyzed by the latest and greatest artificial intelligence algorithm to determine, was the report on the outside, did that radiologist measure my lesions the way that they should have been? And I'll just leave that at there. So I think the cloud opens up lots of possibilities, but I think it's not just about interpreting images, it's also about improving the workflow around them.
Yeah, I would echo that. It's the biggest trends and the biggest excitement is around artificial intelligence and machine learning. But I would not limit it to radiology. I'd incorporate pretty much everything, right? And if we want to focus on medicine, it's still every specialty. Every specialty uses images. Using image ingestion and artificial intelligence on images from every specialty is where our future is. And it does open out to the patient. So you can have apps to figure out what's going on your body in real time. That's where we're heading. It may still be many years away. I'm not sure if that's a 2018 trend. And I think you'll hear a lot about artificial intelligence and machine learning at SIIM. In many ways, we're still in our infancy, but this is where we're heading.
Nice. So you guys have been fantastic. And what I would like to do is we've had a tremendous number of questions come in, which isn't surprising to me. And I wanted to leave a minute or two for us to address one or two of them. Because there's some nice ones here that talk about I'm going to summarize them a little bit. And the question is, how do you one question, I think one broad topic is patient identity, and then maybe managing metadata in connection with that. Why don't we start there? And either one of you can jump in, and then the other can add to it, and then I keep going.
Well,
yeah, go for it.
I'm just saying that it would be really advantageous to have a national patient identifier. That's not going to happen, but I do believe, for a variety of reasons, but I do believe that these algorithms will actually be able to identify patients without having necessary to have a specific identifier, and that would greatly simplify and increase the safety of this image transfer process to assure the images on a patient are attributed only to that patient.
Yeah, I agree. I agree. Having a national identifier would be a nice thing. It would make it a lot easier. It may not solve the problem completely. It's interesting. When I've talked to people from Europe who are in our business, they still have two numbers. There's their national identifier, but there's still a number because there's so many patients coming from outside the country that don't have that number. So they still need to have medical record numbers. We just use our standard way to capture the data coming from our electronic medical record system. If they're not registered, we maintain the data as it originated, and if there is a reference only, we do not register patients who don't exist in our system. If we did that, for us, we don't have the resources to do that.
Got it. And we've got about 2 minutes, and I'm going to throw one more question, which is kind of the flip side of this, which is, how do you handle results reporting? How do you get information back out so that the receiving institution can assimilate it? And Dr. McEnery, you want to start?
Well, we're lucky and fortunate that essentially all our local physicians are on the same instance of the EMR. We do allow physicians or referring clinicians to have access to that platform as well. And the intention is to eliminate not only the CDs but films and faxes to make the availability of information seamless on an electronic platform.
Nice. And Dr.
Yeah, we have two mechanisms. So for our teleradiology practices, we try to send information back via HL7. So we're dictating the report in our standard workflow, and it comes back through HL7 to that institution. For other providers, it's through gateways, through the bidirectional gateways. We're either using our gateway, our hub, or their hub, and sending it through one of them to get it back. It's usually as requested, though, and so it's sending the data that originates at our institution in those cases back to the home institution. If patients are traveling across the country or across the world to us, we then send back the images to them for their care based in their home. But like I said, that's done electronically in the methods that we've talked about.
Great. Well, this hour has flown by, and for those of you who want to get more information, I know both of our panelists are accessible, and we'll make sure we provide the link information. I will also send along all the questions that we got, some of which we didn't have a chance to get to, but there will be an opportunity. There's a good opportunity to take a survey and then apply for credit. So at the completion of the webinar, click the closed webinar pop-up, and that should work well. And then I do hope we'll see all of you at SIIM, and then further on at RSNA. But certainly coming up at the end of May at Gaylord National Harbor, SIIM is every year is better than the one before, but this year I think we have a lot of reasons to be excited about being together. So I want to thank both of our panelists, Dr. Towbin and Dr. McHenry, and Cincinnati Children's and MD Anderson for being so generous with their learning and insight. And I want to thank all of you for your questions and participation in our polls. So with that, thank you all, and I hope I will see you all at the end of May. Thank you so very much.